Hello all, and welcome once again to the Race Academy webinar series, episode 9, the Orthodontic and Restorative Interface, part 2. I'd like to welcome everyone from around the world. Today we have people from Malaysia, Singapore, New Zealand, Australia, Japan, and the United States. So welcome one, welcome all, and welcome back. Oh, welcome aboard even if it's your first time. And I could understand if today was or is your one of the most interesting topics that we've had across all of our webinar series. And today we'll give you the tools for the general clinician or even a specialist to enable them to create space, to correct crowding, to fix rotation, to enhance diastemas, to make room for Maryland and cantilever bridges, or even create the perfect environment orthodontically for that implant placement. Looking at cases orthodontically for the perfect restorative outcome. Something that every clinician really should look at to improve, and definitely something that us technicians do appreciate. Getting the right space to make the case right is no doubt the best. Such an interesting topic today, and who better to deliver this topic than the undisputed champion of orthodontics and today's most experienced orthodontist. So over to you, mate, Dr. Geoff Hall.
Matt, thanks for your kind introduction again, but I think you're probably alluding to the fact that I'm probably the oldest orthodontist around, and that's why I'm the most experienced, but I'll take it as a compliment anyway. So thank you very much for that. Really looking forward to presenting part 2 of the orthodontic restorative interface, basically improving the outcomes for your patient. In part 1, which was last week, we discussed the management of gingival architecture, orthodontic extrusion, and altering that bony architecture. We talked about the management of ankylosed incisors, and we also talked about briefly the orthodontic periodontal interface. In part 2, we're going to discuss guidelines in setting up restorative cases, ideally from an orthodontic perspective. I want to talk about management of missing teeth, management of the worn dentition in adults, and this area which has come under a lot of scrutiny recently, microimplants, or what we call TADs, and really discuss when are they clinically useful and when are they just a gimmick, because a lot of people talk about it and they throw up the word TADs and microimplants without really understanding when to use them. And there's a lot of over-treatment, but they can be really good in certain cases as well. What we want to talk about today is from beauty to perfection. And I think this beauty to perfection, and that's me, okay? And in fact, honestly, you probably get most out of this lecture if I just left on that slide for the rest of the lecture. But I will give you a bit of clinical stuff, okay, as well. So let's discuss the guidance for managing the orthodontic restorative patient. And this comes from the late Vince Kokich, who is the guru in orthodontics and restorative treatment. And we've got to establish treatment objectives, but they've got to be realistic. They've got to be realistic economically, occlusally, and restoratively. So that's really important. We've got to have pragmatic approaches. And to me, we need to create the vision. So it's like doing a blueprint or building a house. We've got to get the plan right. And we usually do a lot of diagnostic setups, or now we're in the virtual world, what we call simulations. And at that point, we then have to determine the sequence. One of the biggest mistakes we make as dentists, we do the same thing every time. And there is a sequence that should be determined based on the type of treatment that you are going to provide the patient. So here we are, where in the old days, we used to use these plaster models. And those, don't get me wrong, those old days are still valid, but we are in the digital world, so we tend to do a bit more digital now. And basically what we can do is a setup of teeth to assess what would it be like if we were just closing up the spaces, how much IPR, or whether we need to do a lower incisor extraction. But it's really important that these are realistic. So when I do this, whenever I do a digital setup or in any set way whatsoever, I leave some teeth on the model. Because if I took every tooth off, I've got no reference. It's like doing a denture setup and everything looks good. So I do it in stages, and I do it with leaving some teeth on the model of the upper arch and the lower arch, so I've got reference that I can utilise. So I'm going to check how much IPR I can do, and then I'm going to close up the spaces. So this was one where I decided, let's have a look at it, what would happen with an extraction case, and how far I would move the teeth. So I've got to figure all that out. Today, though, I'm doing this with these simulations in the digital world, and I can move the tooth down. I can assess exactly how far I've moved that tooth to make space for the restorative treatment. And this was a really interesting case because she needed full mouth rehab, and she went to another orthodontist. The orthodontist basically said, "Oh, we're going to put brackets on your teeth for 2 years." They're going, "Really?" The only real issue was to gain the amount of restorative space in this premolar region. So we did a simulation, and I thought I could do this in about 4 or 5 months with just some partial braces, and that's what we did. But that was with the benefit of these digital simulations. So let's talk about how do we look at managing the orthodontic restorative space, the restorative patient. So for example, small teeth, a lot of patients have got small upper lateral incisors. And we've got to make a decision. Do we build them up prior to orthodontics? Do we gain space and then build them up, et cetera, et cetera? Yeah, and the classic would be the small upper lateral incisor. So where are we going to position that lateral incisor from an orthodontic point of view to give the patient the best aesthetics? Because everybody would say, well, we're just going to position the lateral incisor in the middle of the space. But we have to look at it from the buccolingual position, the mesiodistal position, the incisor-gingival position, because as a restorative dentist, you want to do minimal preparation on these small lateral incisors. So we've got to position them ideally. So the first key is, where do we position them mesiodistally? And if we leave all the space mesial, we're going to end up with this black triangle because we don't have a flat line angle. So if we move the tooth and put all the space distally, we're going to have the same situation. So in these type of cases, what we want is we want to have a flat line angle to reduce that tendency of the black triangle that we spoke about in part 1. Because what we know is that if we've got the contact point within 5 millimeters of the bone, we will not have a black triangle. So we want to get a flat line angle. So in order to do that, we've got our central incisor here. The ideal positioning of our peg lateral or our small lateral incisor would be, we have 1/3 of the space mesial and 2/3 of the space distal. So we basically go ahead and say, we're going to have 1/3 of the space mesial, 2/3 of the space distal. Then you can do the correct build-up of the tooth. Okay, so that is absolutely critical to the success of an aesthetic result. So, or do we open up the space and make sure, once again, we've got 1/3 of the space mesial and 2/3 of the space distal. Okay. So Vince Kokich, this is one of Vince's cases, and this is what he did. He ended up opening the space, 1/3 mesial, 2/3 distal. And then he built the tooth up and we closed up the space. Now, what's really interesting here is how many, you've got to remember that there should be a team leader, and the team leader should always be the end person in the chain of treatment. So in a case like this, the team leader is the restorative dentist, which is probably going to be you as a general practitioner. So if you're working with an orthodontist, or even if it's yourself doing the orthodontics, you've got to say to yourself, how am I going to do it? Or how do I want to work with a specialist? And after 30 years of making so many mistakes, I've come up with a really easy system. And I'm sure you in the audience will have worked with orthodontists in the past, and they've given you the wrong amount of space. They've taken the braces off, and you go, what can I do now? So the way I do it is I open up the space with my braces. I open up the space and I make extra space. I then take the bracket off like I've done here. I take the bracket off. I get the dentist then, or the restorative dentist, to build up the tooth to the correct size in composite. And then I go ahead and close the rest of the space. So there should be no argument ever that we haven't given you the right space, because you've now built up the tooth to the correct mesiodistal width. So that at the end of the treatment, whatever veneer you're going to do will have the right mesiodistal dimension to it. So if we look at this girl here, Sarah comes in with a small upper lateral. So what we're going to do is open up the space for this tooth. So we're going to open up the space first. So I've opened up the space and I've made it a lot bigger. Then I've taken the bracket off. I've sent the patient back to the dentist and he's made a composite crown on that tooth. And now I'm going to go ahead and close up the space. And now we should be able to close it up without any issues. And it should be the same size on the right as the left. So everything's done with references. And here we are. And now you can go ahead and put your veneer on and everything's done absolutely perfectly. Okay. Now, I'm not saying this is a perfect cosmetic result, but we've got the right space that you can now provide a perfect cosmetic result. Bit of crown lengthening, get the gingival margins right, etc., etc. But the key here is open up the space first, build up the tooth to the correct size, and then close up any remaining space. And that's what she looks like. Now, if you've got a Maryland bridge, and this is why we need to plan things properly before we start, because it's a different setup ideally if we're doing a Maryland bridge compared to doing a conventional bridge. Because if you're doing a conventional bridge, you want to leave about 3/4 of a millimetre of overjet to make room for your restorative material on the palatal surface. On a Maryland bridge, you actually want to make sure you keep these incisors vertical and we minimise the overbite. You want the least amount of lateral excursions on that Maryland bridge. So we've got to look at managing this patient differently depending on what our restorative requirements are. So this comes back to what we talked about. This comes back to what we talked about in our part one. We look at the wear of this patient's anterior teeth, and we've got extrusion of the teeth because of the wear, differential extrusion of the teeth. So we've got to now say, how are we going to position these teeth for final restorative work? So we've got abraded incisal edges, and if you remember from part one, we would do two things to verify our diagnosis. We would look from the incisal view, and we would see that the thickness of the incisal edge is much greater, demonstrating that we've had wearing of that dentition. And we could also perioprobe and see that there's no pocket there. The CEJ is in the right position compared to the gingival crevice. So this is the case where we say, okay, it's differential extrusion of the teeth. Let's go ahead and intrude these teeth, level the gingival margin, and then we go ahead and restore these worn teeth. Once again, it's the staging of treatment which is so important. So, for example, we've gone ahead and we're going to put brackets on. Look at the wear of those teeth. So, how would you go ahead and restore that patient in that situation? Just about impossible. Okay, so we go ahead, we put our brackets on. We've now intruded the gingival margins that we've talked about, and at this particular point, I'm going to take the brackets off. I'm going to send the patient back to the restorative dentist, and I'm going to get him to build them up in composite. So he's going to give me references. So we go ahead and we're going to build these up. We've taken off the anterior brackets. We've built them up in composite. I'm now going to put the brackets back on, and we're just going to finish off the posterior occlusion. So I've now got a reference of the anterior position of the incisors. I've got a reference of the overbite. I've already built up those worn anterior teeth. The rest of it's really easy. So at this particular point, he's now ready to have his final prosthetic treatment done. But the key is sequencing the treatment. And once again, everything we talked about in part one of diagnosing it correctly, making a decision as to why we've got unlevel gingival margins, wearing of the teeth, and now we can restore them. And we can do this in composite, and then later on, they could be done sequentially if you wanted to with the crown and bridge work. And there's no doubt he's like a posterior bite collapse patient. At some stage, we're going to need some implants put in posteriorly, etc., etc. So what about when we've got missing teeth? Because we hear this all the time. So the way I look at patients who have got missing teeth, I pretend that the patient has all their teeth in place. And I say to myself, if you had all your teeth in place, are you a non-extraction case? Are you a black and white non-extraction case? Okay. Or I say, are you a black and white extraction case? So if they're a black and white non-extraction case, we're not going to close up the spaces with the missing teeth. We'll open the space. If they're a black and white extraction case, perfect. We can then close the spaces for those missing teeth. And then we've got these quite a lot of patients who are in that borderline category, and we may consider on those ones closing the spaces. But the point I want to get at is if it's black and white non-extraction, do not close the spaces because you think we should close them because they're missing teeth. We've got to look at the patient from a diagnostic point of view. So, for example, when we're looking at single tooth implants, we want to make sure that we have the right space for implants for the lateral incisors. And usually it's about 2/3 of the width of the central incisor. Now, the problem here is we've got to make sure not only have we got enough space between the crowns coronally, but we need to find enough space between the roots of the teeth. That's the hard part, because whenever we put a spring between the teeth, there's a tendency for the crowns to go and spread out, which is what we want, but there's a reciprocal effect of the roots coming together. And you'll see that from a lot of orthodontic cases that the crowns may look great, but the roots have moved together and there's now not enough room to put the implant in. So you've got to understand some biomechanics here. How do we move the roots apart as well as the crowns? That requires a little bit more education. So we all know that you need at least 6 millimeters of width in the laterals to be able to get a decent implant in there, okay? So this is, once again, based from Vince Kokich. He put a coil spring in, and this is the typical appearance. If you just put a coil spring in, you'll get root convergence, even though the crowns appear apart with enough space clinically, but you've got to make sure the roots are divergent. Back in those days, we only had periapical radiographs to assess that. Now, fortunately, we've got cone beam, which is the standard of care without a doubt. So we've got to make sure that when we get the space, we get the space not only for the crown, but also for the roots. And this shows a beautiful implant site where anybody can put the implant in. That's what you want. So we want to make sure we've got enough space, not just between the crowns, but also between the roots of the teeth. This is where the cone beam is now the standard of care. So this girl comes in and she's missing her upper lateral incisors and she's got a deciduous canines. And if you remember from part 1, when we talked about bone regeneration, the best scenario we have is the canine erupting right next to the central incisor. Because what we want to do is at some stage take out the C's. So we take out the C's and we're going to distalize the canine back, and that's where the good bone is. So we now, hopefully, if we do that, we'll have good bone in that where the permanent canine is now, or where the lateral incisor implant will be in the future. Now, I'm going to get to this in a second. It's a perfect class 1 molar and premolar relationship. And whenever you see a class 1, you say to yourself, I would prefer to not extract in this case. So as soon as I see this beautiful class 1, I say to myself, this is a black and white non-extraction case. Hence, we should open up the space for the missing teeth. And this, so whenever we do that, we're going to do a diagnostic setup. And this is what we've done so to make sure that's going to work. Because if I can't get it to work on plaster models or on a simulation, it will not work in the patient's mouth. So this is the way I test it. So I go ahead then and say, great, let's put brackets on and look at the bone. We've got a beautiful class 1. We've taken out the upper C's. We've distalized the teeth. And the bone is great because we've got bone regeneration as we've moved the canines distally. And remember, we still got to look at the height to width ratio, because if we're going to do a veneer on that tooth in the future, we also need to increase the width as well. So we've made a little bit of extra space. And this is working with you as a restorative dentist. And here we are opening the space. Now, what I've done is I put Pontic teeth. I put Pontic teeth on the wire. So once I got the right space, I sent them back to the restorative dentist and said, could you please make me Pontic teeth of the exact perfect size that you want in the future? That way I cannot close up too much space. Once again, a problem that we can have in the future. So it's all getting references. So I referred them back to my prosthodontist at the time, and he made up acrylic Pontic teeth of the exact size, and then I put some brackets on there as well. So here we are with a very nice result, and he's going to finish this off with, I think it was Maryland Bridges or whatever it was going to be. So here we are at the, that's where I finished them off orthodontically. I bonded a powder wire on the upper centrals to make sure the diastema wouldn't open. And then he did some Maryland Bridges. I think they were Maryland Bridges in the interim. And then after that, they would be definitive implants. So this girl comes in and she's got a class 2 buccal relationship on her right side, and she's got a 50% class 2 on the left side. And she's missing her upper left lateral. And her upper midline has moved across about 3 or 4 millimeters to the right. Okay, so she's a class 2. And sometimes in a class 2 patient, you can extract in the upper arch. Okay, so I look at this patient here, and some of you are going to say, well, I'm going to take out the upper left 4. I'm going to open up the space for the upper left lateral, etc., etc. And I thought to myself, let's think outside the box here, Jeff. I want to get a good restorative option. If I could get symmetry in this upper arch, because from what I understand from technicians and restorative dentists, the key to a successful result is actually symmetry. So I took out the upper right lateral. And a lot of you people are going to go, you can't do that. Of course you can. You can do anything you want if you know what you're doing and you're abiding by correct principles. So I took out the upper right lateral. Now I've got symmetry in this case, and I believe I could extrude these teeth, get the gingival margins right, and do some very simple restorative dentistry on this patient. I've been able to get the centre lines correct, etc., etc. So what could be a very difficult problem, I found a very easy solution that can now be resolved very, very simply with simple restorative work by you guys. This case is quite fascinating. Changed my life in a way. She is 12 years of age, missing her upper lateral incisors, as you can see. One deciduous canine still present, but a perfect class 1 buccal segment. And so I look at that and I say to myself, non-extraction, perfect class 1, let's avoid extractions. So I've gone ahead and like I did with that previous patient that you saw, I opened the space for the missing lateral incisors, and we've got beautiful bone here, and we're going to go ahead and we're going to put in eventually implants, etc. But I did my diagnostic setup. So this is going back 20 years ago. I did my diagnostic setup as well to make sure it's going to work. I did what we call a Bolton analysis, and that verified that I could either reduce the lower tooth structure by 12.5 millimeters, extractions, which I didn't want to do, or I could increase the upper tooth structure by 16 millimeters, 16 millimeters being 2 lateral incisors. So I did the diagnostic setup and everything worked very well. So we went ahead and we did a Maryland bridge as an interim. So this is going back 2000, and ideally she would be having a implant in both these. Okay, so that was Sarah. Sarah's, and you can see this was a beautiful result. Look at the root divergence here. Everything turned out perfect. But Sarah's sister came in the same time, Dominique. So Dominique came in missing upper laterals. But when I looked at it, she had a class 2 buccal relationship. And so I did a diagnostic setup. And I did it with closing the upper spaces. But in order to accomplish that, because of the Bolton discrepancy that happened because of the missing upper lateral, I also had to take out one lower incisor. And you're going, and so here I am seeing mum with one child, and I told mum, we're going to need to open the spaces, put 2 implants in. Your other child, I'm going to close the spaces, and I'm going to take out a lower incisor. And the point I'm trying to get at here, you've got to make the diagnosis and the treatment fit the individual patient and their problems. There is not a cookbook that we're going to always do open spaces. I hear this from so many people. I always open spaces or I always close spaces. Let's look at it from an individual point of view. So I did a diagnostic setup and with the removal of one lower incisor and closure of the upper spaces. And this is what solved the patient. It's no different to now what you guys are doing with DSD and digital smile design, because you're showing them the 3-dimensional view of what's going to happen. And that's what they're paying for, is your knowledge and your skill. So here we are. To prove the point to you, I've taken out the lower incisor, I put my brackets on, I've leveled and aligned, and I'm not going to say this is the best case I've ever done either, but I've done all that, and here we are, finished. And once again, now I've got symmetry in the upper arch. You can do some veneers on those upper laterals, on those upper canines. The gingival margins are pretty good from a cosmetic point of view, and she doesn't need any major restorative work because she was basically an extraction case. So here we are. So mandibular premolars, I'm going to give you some ideas of what you can do if you know what you're doing, because that's probably the second most common missing tooth. 7 to 8 millimeters in width is what we want, but the deciduous molar is about 10 millimeters. So we've got a couple of options. One option is we reduce the size of the deciduous molar and we use that as a space maintainer. So for example, here, if the deciduous molar was here, I could reduce the size, but we only want about 7 millimeters of space at the end of the day, okay? So one option is to go ahead and build up the deciduous molar and trim it down mesiodistally to 7 millimeters. Because when we do that, we can then move the molar forward into this extra space and we get this nice occlusal scheme. So with these E's, we go ahead and we build up the occlusal surface, we reduce the mesiodistally to 7.5 millimeters and close up any space. So then when that E exfoliates in the future, you've got the perfect dimension to put an implant in. So that's one option that you can do, which we do very, very often. And we'll talk about another option, I think, later on. But this was what was really interesting. Going back 20 years ago, I was told that we really wanted to avoid canine guidance on our prosthetic replacement of teeth. Now, it may not be as important today with implants, but from what I understand, even implants, it would be best if you don't load them laterally and you load them more from a vertical point of view. So this was a case which was really very interesting indeed, because we were missing the upper left fork, and this changed my whole philosophy of treatment. So, for example, this case up here, the prosthodontist was replacing the canine. This is going back 25 years ago, and so he had to make a canine which was very, very small in size to reduce the lateral loading. That's what we did back then. Okay? So the dentist asked me 20 years ago, Geoff, is it possible to move the four forwards. And I said, well, we'll give it a try. So what we basically did was we moved that 4 forward, and we could do the bridge at that time. It could be an implant with using the abutment on that 4. So let's show you what it looked like. Here we are. We moved the 2-4 all the way forwards, and look at the great bone. I go, wow, this is fantastic. So now the dentist could do a bridge from the 2-4 to the 2-6, or an implant, whatever he wanted to do. There was no loading of that canine. So from a functional point of view, it was pretty successful. And that changed my mind in how we could move teeth in restorative work. Okay, so this was me when I was much younger. So let's have a look at, once again, the missing lower 5. So you've got the E here, and a lot of the time when those E's are submerged, the bone hasn't grown. So if the bone hasn't grown, what happens? You get a defect and you need to do bone grafting. And that's what most people do. They take out the E, they're going to do bone grafting, etc., etc. Look at the narrowness of the ridge. And a lot of people say, let's try and move the 6 forwards, but you have issues there because of the roots of the 6. But what about, we now know about bone regeneration. So what about moving that 4, the good 4, distally, where the good bone is, and we move that all the way distally. And that's what we're doing here. We're moving the 4 distally, and now we've got the bone right in the good bone in that old 4 side. So now you can go ahead and put an implant in there without any bone grafting, etc. So once again, another option for you guys if you want to avoid bone grafting, etc. And then you may say, but Geoff, I need to hold it. How do I hold it? Well, there's all simple ways that we can do it, where we can just bond wires on to hold it until they're ready for the implant. And we put the implant in. Another case of Vince cocages. But I'm just trying to give you some different options to understand what can you do when you've got these missing teeth. So to go back here, my decision process whenever I see missing teeth, if it's a black and white non-extraction case, I don't care how, we're going to open the space and we're going to prosthetically replace the teeth. If it's a black and white extraction case, fantastic. I'm going to close up the spaces of those missing teeth. And it's these borderline cases where you may consider closing the spaces, but you've got to be very careful when you do that, okay? So, interesting case here, because this patient went to another orthodontist. And this patient came to me, and the other orthodontist, so the patient came to me, patient missing teeth. So we're missing one premolar on the upper right side. We're missing nothing on the upper left side. We're missing one premolar on the lower left side, and we're missing 2 premolars on the lower right side. So the patient came to me, another orthodontist, and the nut of an orthodontist said, why don't we transplant this particular tooth into this site? And we're like, okay, really? Yeah, and if I was face to face with you and face to face with Matt, people are going to say, you're right, Geoff, he's a nut, that other orthodontist. Okay, imagine us suggesting that. Okay, imagine suggesting that. Well, I lied to you. You never went to another orthodontist. That was my treatment plan. Okay, that was my treatment. And one of the points I want to take home from here: don't criticise other people until you know a lot about what's going on, because that was my treatment plan, to transplant this particular tooth into that site, because I got the patient early, and this is part of our early treatment. And this is exactly what we did. We transplanted that tooth into that site. So basically, we ended up in a typical orthodontic 4 premolar extraction case, because remember, he was missing one premolar on this side. He had both premolars on this side, so we took out one and transplanted it. He was missing one premolar on this side, and on this side, the lower right, he was missing 2 premolars, so we transplanted it across. And I won't get involved in the intricacies of transplanting because that's another topic, but Zachrison, he's been doing it since 1960. And they did a study, I think it was 300 cases that they did. They had a 96% success rate with transplants if you choose the right timing for it. And the right timing is when you've only got half to 3/4 of the root present. So if you catch these people early and you plan it properly, so this kid got treated. So this is back in 2002, 18 years ago. So here we are, 2002. This is the transplanted tooth. This is how he finished. This is finishing up. Initial. He had some crowding here. We're closing up some spaces. And this is how we finished. That's the transplanted tooth here. Now, considering we've avoided the need for any prosthetic replacement, and even your worst scenario, because somebody's going to say to me, Geoff, but that had a bit of an endo. And what's the worst thing that can happen? That tooth fails and you need to do an implant in the future. But because that tooth is there, we've maintained the bone for a long period of time. So whatever way I look at it, apart from a minor surgical procedure, we've done a big service for this kid. So that's the implanted tooth, or transplanted tooth, I should say. So management of the worn dentition in adults. So we've got to look at, you must see this all the time in your practice, deep bites, worn dentition. So we've got to assess the etiology, the facial appearance. So we've got to make diagnostic decisions. Do we intrude the upper and lowers? Do we procline them? Do we level the curve of speed? And once again, this is all diagnostic part. But this lady comes in and you're going to see pretty severe wear of the teeth in a second. So she comes in and I notice the gingival margins are not coincident, so I'm wondering what's the cause. So have a look at this occlusally. Now, the nice thing about her is if you were doing endo, you couldn't miss finding the pulp. You couldn't miss. So we basically went ahead and intruded these anterior teeth. So we intruded them, and then we just put some metal backings on to protect the teeth. Yeah, very simple. So because the last thing we wanted to do here was to do any further reduction on the palatal surface of the teeth. This lady comes in, deep bite. Look at the wear. I'm sure you guys have this all the time. And we just did this with a removable appliance. And we opened up the bite posteriorly because she didn't want to have appliances anteriorly. So all I did was open up the bite posteriorly, sock in the posterior occlusion, and then you guys could go ahead and do your restorative work anteriorly. But we needed to open up the bite. So once again, the staging of treatment is important. Okay. So, and this lady comes in, and this is a very sad lady because 2 of her children committed suicide whilst they were in treatment with us. So she now works for the suicide prevention group. And look at, this is what we call a broken down worn dentition. Now, tell me, how do you restore her in any way without using an interdisciplinary approach? So we did a combination of endo, ortho, implants, orthodontic surgery. She had the whole works. So we lined her up. We did orthodontic surgery to bring her jaw forwards, and then we put implants in, etc., etc. And I say we, the periodontist. And so let's have a look at how she finished. So you got all the implants. She went through a lot. So that's where she started. And look at the final result. This stuff is life-changing. And you don't have to be a great orthodontist. You've got to be a good diagnostician and treatment planner. So this is what she was like before. This is what she's like afterwards. And another one, where I still see her son. So she started off, and you've got to say that's a pretty traumatic occlusion. So we've gone ahead and we've done a combination of braces and orthodontic surgery. So sometimes these patients with deep bites, worn dentition, may require an interdisciplinary approach that does require orthodontic surgery. So we can then set her occlusion up perfectly. And so you have a look at, that's a beautiful result. Look at the difference from before to after. This was life-changing for her. 2 divorces later, she's very happy. So So look at the difference in a profile and her occlusion. And I would argue her perio is far better today than what it was before because we've set up her occlusal scheme far better. Okay, so just to finish up for the last few minutes, let's just talk about microimplants. Because we talk about Anchorage, and Anchorage has been something we talk about a lot in orthodontics. And we use the term minimum, moderate, and maximum Anchorage. And Anchorage is basically resistance to Newton's third law. So it's a resistance to displacement. Okay, so basically we want to resist movement in some way, and that's what Anchorage is all about. So we can use what we call indirect anchorage, because when you've got a coil spring in here, there's a reciprocal side effect to move these anterior teeth forwards. And if we don't want that to happen, we can use a micro implant to hold that. And this is where it can become very useful. So it will hold that. Where I see micro implants really useful is in these over-erupted posterior segments, because one of the most difficult orthodontic movements that we can do is intruding posterior teeth. So we can put micro implants in, usually both buccal and palatal for biomechanical reasons, as you can see right here, and we can intrude these teeth very effectively and give you the interocclusal space to restore the lower arch. Because the beautiful thing is once you've restored them with your implants, that is your retention. They can't extrude any further. So this is what we do a lot with our micro implants to intrude these over-erupted posterior teeth. Very, very useful when you've got over extrusion of the posterior segment. And we could, I don't believe in this very much because I find a lot of relapse, but this would be typically an orthodontic surgical case. And people in Korea used to do intrusion of these posterior segments. And so we can intrude them, but I think that's a lot of work. I think it's probably a bit more predictable to do this with orthodontic surgery. Ideally, there's less relapse, but sometimes it's worth a try if the patient doesn't want to do orthodontic surgery. And to finish up here, this is a patient, a kid comes in, and we're once again missing the upper canine, the upper laterals, and we've got deciduous canines. Now, I've said to you before, if it's a black and white non-extraction case, I would not extract. And this is exactly what I told Mum. I said, Mum, this is a beautiful class 1. We should open up the space and put in some prosthetic replacement of the missing lateral. Mum said, no, I want to take this out and I want to move these posterior teeth forwards. What we call minimum anchorage. That's the most difficult thing to do orthodontically. So the only way we could do it was to put a TAD or a micro implant in here, because if we put power chain on, there will always be some reciprocal side effect of the anterior teeth coming back. We could not afford that at all. So because Mum wanted no implants in the future or no restorative replacement of those missing teeth, we had to use minimum anchorage, and that's the useful part for TADs or micro implants. So we used minimum anchorage. This is the type of thing for minimum anchorage and for maximum anchorage where micro implants can be useful. Otherwise, there's a lot of bull dust that goes out there that's said to you by the implant companies. So by doing that, we can now move the posterior teeth forwards without moving the anterior teeth back. And that's what we started to do, and we ended up with not a great result, but a very acceptable result on the basis that this was a real compromised treatment plan. It was not what I recommended at all. So to finish off, there's this boy here. Look how difficult this case. 12-year-old boy missing his 4 lower incisors. This is his presenting occlusion, and he's got a buccal overjet or a scissor bite, basically, or what we call a Brody syndrome. So we basically said, let's put in a micro implant because we need some extra anchorage. So we put the micro implant in. We started to intrude these teeth because we had a cant of the occlusal plane. So this would not be somebody doing orthodontics with their first case. But what I want to show you is what we can achieve with working in an interdisciplinary approach. So we went ahead and intruded these teeth. We could go ahead and put some brackets on the upper teeth. And at some point, we go, you know what? We could now go ahead and build up these teeth like we did for all the other patients and gain some references. And that's what we did. We re-bracketed the teeth. We're opening the space. So we're going to end up with a 4-unit bridge on the lower anterior segment. So just you can see how it's all coming along. This kid, when they first started, looked like this. Okay, well, actually looked like this. And here we are now. So here we are. Let's go to. So we're now leveling and aligning. Just to give you an idea, we're about 18 months into treatment. So we're going to take out our tab and we're going to end up putting in 2 permanent implants. So look at how the anterior teeth has corrected. We'll end up taking our tab, and Andrew Dillon's going to do a 4-unit bridge. So he's going to put together now a 4-unit bridge. So look at the difference. From there to there. Now this is just a temporary bridge. He's going to have the permanent bridge done later on. But all because we set it up in the right way. And you can even use these temporary implants as a way to hold the bone. So what we talked about before with Maryland bridges, I think today you can put a temporary implant in and build that up with a temporary crown, and you can hold the bone in preparation for your future implant later on. So to finish up very quickly, you know about me with Ortho Ed. I'm not going to go through it all, but if you want to learn more about any of this stuff, we're happy to talk to you. We go through the entire gamut of orthodontic training, from diagnosis, treatment planning, even aligner therapy, and all to modulate, which is where you would see all of this stuff on IDT and the management of difficult orthodontic problems. So what you've seen in 2 hours, we spend 2.5 days on, and we go through all this in detail. And so we got lots of testimonials, etc., etc. If you would like just to have a chat to me, just go to orthodontictraining.com.au/session, and happy to have a 45-minute call for you, no obligation. But remember, through RACE, because they believe, Matt believes, RACE believes, and what I believe so much in education, that we've basically done a deal where RACE's clients will get $3,800 worth of RACE dollars as credits for lab work. You've just got to use a special link. So if you just speak to RACE, they will give you the special link to if you want to use that and qualify for that, because this is a given to you because you're a RACE client. And and I've got to thank Matt and everybody else at RACE because of their foresight, understanding what education will give to their clients as well and make you better dentists. So on that note, happy to take a few questions, Matt, but I hope you got something out of that presentation.
Yeah, thanks, Jeff. Oh, look, unbelievable. Your presentations are amazing, and the detail you go to explain these things. Look, as a dental lab, Jeff, we see these issues all day, every day. Not enough room for the restorative outcome, too much space for proportionate restoration outcomes. Constantly tackling this. Why do you think dentists don't take an orthodontic approach to the case planning from the start? Is it a lack of time, a lack of care, or simply a lack of knowledge?
I think it's a lack of knowledge, in all honesty, because I think orthodontists have hidden stuff from them, okay? And so they think it's the too hard basket. And with all due respect to my orthodontic colleagues, they don't understand working with the dentist as well, because it's not. I've seen this happen, and I made those mistakes as well. We would take braces off. It wasn't right. The dentist told me I wanted this and I wanted that, and that wasn't what I thought. And it really is learning to work as a team. And I think and there has to be better communication between everybody.
Sorry, go on.
but there has to be a fundamental knowledge of what can the orthodontist do, or what can they do if they understand orthodontics as well, and then understanding sequencing the treatments. I think one of the big problems, when I speak to my prosthodontist friend Andrew Dillon, everything is staged, so nothing can go wrong, and I think that's where the difference lies. And if dentists were doing that as well, they've got their stents made up, nothing can go wrong. They've got to plan it, because we spend 80% of our time fixing up all the problems that should never have happened in the first place. And I think you've got to sit back and spend a bit more time in the planning of care, and you're going to end up having, I think, a much better life. Since I've been doing that in the last 15 years, my orthodontics and my enjoyment has been much greater.
Yeah, right. We see a lot of these big veneer cases coming in, predominantly in our high-end veneer department, where the clinician tackles rotation or crowding aggressively and invasively with a burr instead of straightening the teeth and whitening the teeth. And quite often it's unnecessary to go on to the veneer or the restoration stage. And that approach not only pushes the limits and the boundaries of us technicians and our lab, but also the capability of the restorative materials themselves. And you mentioned earlier about the long axis force on the implants, and it's the same with restorative manufacture. Too much of that canine guidance, group function, or lateral protrusive excursion of that mandibular can really damage the long-term success of those restorations. So it was an eye-opener today to hear other things that you went on with today, Jeff, like the deciduous reduction, something that so many clinicians wouldn't probably have thought of, and to see the detail you go to help in what probably is a reasonably simple process to get the results. But one gentleman here has asked, a lot of these cases have been approached using braces. Can the clear aligner therapy do the same thing?
It's funny you say that, because I was actually going to interrupt you just then and say, now that you guys are getting into clear aligners, my feeling is 90% of those cases I showed you today, if you knew what you're doing with clear aligners, you could do it with clear aligners. Right. Maybe 95%, okay? Because the principles don't change. Some of those, the patients where you've got over-erupted posterior teeth, maybe you can use clear aligners in conjunction with microimplants. But you can do so much with clear aligners today. My partner, Martin, 90% of our practice for him is clear aligner therapy. But you need to know what you're doing. So, right. And that's what I was going to say. I think when you open up your clear aligner market, you can do a lot of this stuff, because these patients, unfortunately, they don't want to have braces. So I understand exactly what the dentists are talking about. But if you know what you're doing, you can do all of this with clear aligners as well.
Right. Look, I don't have a question here from Singapore, but one person's written here, look, I now understand the importance of the interdisciplinary approach. Thank you, Jeff. So, look, it's appreciated by all, and it's super important that we all play our role in the final outcome for the care of that patient.
Absolutely. And if you ever, just as a final side, my advice, and this may be something that you guys may want to do, is to set up a whole interdisciplinary team. Right. Where cases come in, and people can ask the prosthodontist, the endodontist, but I think one thing that's been missed out on is the technician. And I think it's really important for the technician like yourself, Matt, to be involved in that, because that takes another dimension to the treatment plan, which we as dentists don't understand.
Yeah, right. Look, there's no doubt understanding everyone's importance in the role is going to improve the outcomes and no doubt the longevity of that. Jeff, I've got a plethora of questions. We're running low on time. I'm just going to throw them out real quick. Someone's mentioned here the use of one wing in your Maryland. Would you always recommend one wing over two?
Well, I'm going to leave that as a restorative option. Well, what's interesting, when I speak to Andrew Dillon, what he said, he likes one wing Maryland bridges, okay? Because in case one wing falls off. However, if you are using, what he says to me, if you're using a Maryland to hold the space for a future implant, he wants a two-wing Maryland bridge, because that'll reduce the risk of the roots moving together.
Okay.
But depending on what your final approach is going to be, if you're using your Maryland as an interim for your interim cosmetic appliance in preparation for an implant in the future, he would use a 2-wing Maryland in those cases.
Okay. Well, that's fantastic, Jeff. We have run out of time today. I wanted to thank you on behalf of all the people that signed up across the globe. Thank you so much for your time, Jeff. Your comprehensive approach and your knowledge on the subject is first class, mate. Welcome to the pointy end, and I hope everyone here has got a lot out of what Jeff's delivered today. Don't forget, next week we go on to episode 10, which is tips and tricks for intraoral scanning and prepping for today's technology. So look, we hope you all can sign on next week. Dr. Geoff Hall, again, thank you so much. It's much appreciated, and I hope to see you all next week. Thank you so much for your time.
Matt, thank you for everything. Really appreciate our friendship. Thanks a lot, Matt.
All right, see you all next week. Thanks, guys.
See you. Bye-bye.